We are going to discuss today about the Acanthamoeba keratitis. In the last lecture, we discussed about the bacterial keratitis or ulcer, viral and fungal. And another is the Acanthamoeba keratitis. It is a protozoal infection, air or soil-borne infection. When the water of the swimming pool or water is contaminated with the soil, the cysts which remain in a dormant stage, they invade in the injured cornea, causing keratitis. The cyst breaks into trophozoite and form an invade, causing the keratitis. The sufferer are the contact lens worker, swimmers, and agriculture workers. They are the sufferers of the Acanthamoeba keratitis. अर्को आएन नि त अर्को टपिक आएन तल चेन्ज भएन यो अर्को थियो Look at this picture. You can see the ring ulcer. This is the contact lens wearer. When the contact lens wearer washes his face with the contaminated soil, contaminated water, then the trophozoite of the protozoa, they invade in the cornea and cause the ulcer. Usually in the contact lens wearer, there is usually injury of the cornea. So that the trophozoite enter into the injured cornea, causing the ring type of ulcer. Clinical features. Superficial punctate keratitis, pseudodendrites, ring ulcers, they are seen. In the corneal scraping stain with the chalcophyr white, that gives the staining of the protozoa. Corneal biopsy, that also can demonstrate the protozoal cyst. These are the investigations which are necessary in the Acanthamoeba keratitis. Treatment: combination of dipropamide and polyhexamethylene bigunite drops. Combination of dipropamide and polyhexamethylene bigunite drops. They can be given depending upon the severity 2 to 4 hourly in a day. Metronidazole tablet, which is anti-amoebic drugs, which can be given orally 3 times a day after the food. And neomycin drops, propamide, isthionate, ointment and drops. And if the condition is not improved, then you can plan for the penetrating keratoplasty. Marginal ulcer. Peripheral ulcerative keratitis. When the ulcer occurs in the margin, in the limbal area, this condition is known as the marginal ulcers. The causes are when there is ischemic necrosis of the limbal vessels, then the collagenase enzymes, they are liberated and they cause the ischemic changes and cause the ulcer. There are 2 types, unilateral, which usually occurs in the old age and which is non-progressive. Another is the bilateral case, which is progressive, which occurs in the young, but perforation rarely occurs. So there are 2 types of marginal ulcers. One is which occurs in the old age, which is non-progressive type, and next is the progressive type which occurs in the young, and it is bilateral. It is due to the ischemic necrosis of the limbal vessels. When there is ischemia of the limbal vessels, there is collagenase enzyme and proteoglycolate enzymes. They are liberated, they destroy the cornea and cause the ulcer. The picture is not clear. You can see the ulcer at the peripheral side. Treatment. In case of marginal ulcer, the treatment of choice is the steroid drops. Depending upon the severity, you can give 4 times or 6 times a day. And systemic therapy like oral steroid or antimetabolite like cyclosporins, they can be given. Next is the surgical treatment, excision of the 3 millimeter of the cornea around the ulcer area. This is the best method so that the enzyme will not replicate and will not disturb the cornea. Band keratopathy. This is one type of keratitis where you can see the band-like structure in the cornea, the central part of the cornea. There is deposition of the calcium salts in the subepithelial space and the Bowman's membrane. The causes of band keratitis are chronic iridocyclitis in children, idiopathic in old age, thysis bulbi. Clinical feature, band-like structure insists in interpalpebral space of the cornea. Treatment, chelation with EDTA, ethylene diamine tetraacetate, chelation with ethylene diamine tetraacetate. We can do the corneal scraping and remove the band. And sodium, solution of the sodium arsenate, 0.01 millimole per liter. They can be given locally. And excimer laser keratopathy and lamellar keratoplasty. These are the treatment of choice in case of band keratopathy. Corneal dystrophies. There are some corneal conditions where the dystrophy of the cornea occurs. There are different types of corneal dystrophy, anterior, stromal, and ectatic dystrophies. Anterior dystrophies, where the epithelium is undergo dystrophies and causes the corneal opacity. In stroma, the stroma undergo the dystrophies and causes the opacity. And there are some ectatic dystrophies like keratoconus, pellucid marginal degeneration, keratoglobus. And another, there is posterior dystrophy also where the endothelium is involved. Clinical, it is spontaneously appears, it is inherited. If there is family history, then the sufferer will be it is inherited. If the parents have dystrophies, then the siblings can have the dystrophies also. It is a bilateral condition. It is slowly progressive, but it is non-inflammatory. There is no sign of inflammation in this case. It appears in adult life and vision is gradually lost, or sometimes vision is very reduced. Now we can see the opacity here. You can see this opacity is in the cornea in the slit lamp examinations. You can see the opacity in the stroma. Among this opacity, the keratoconus conical cornea is important, which you should know. You can frequently see such cases. And it is a common progressive disorder of the cornea. The cornea assumes a conical shape. Central or pericentral thinning of the cornea occurs. The apex of the cornea is protruded. There is irregular astigmatisms. age starts at the puberty, 85% are the bilateral and the both sexes are affected. Now we can see in this case, conical cornea. When the patient looks down, there is notching of the lid. This is another monsoon sign. This conical cornea, keratoconus, is associated with the different diseases: Down syndrome, Turner syndrome, Ehlers-Danlos syndrome, Marfan syndrome, osteogenic imperfecta, and mitral valve prolapse. These are the systemic association of the keratoconus. Other associated ocular conditions are Barnard keratoconjunctivitis, Leber's congenital amaurosis, retinitis pigmentosa, blue sclera, aniridia, ectopia lentis, constant eye rubbing, and hard contact lens wearer. These are the associated ocular conditions where the keratoconus can be seen. There are different types, mild, moderate, and severe, and the patient presents with impure vision due to progressive astigmatism and the myopia. As the corneal anterior posterior diameter is increased, the patients will have the myopia. As the apex of the cornea is increased, there is irregular in the corneal surface, so that as there is progressive astigmatism. The patient wants to change the glasses frequently, and the patient cannot tolerate the contact lens. As the cornea becomes cone type, so the patient is unable to bear the contact lens. Sign: the bulging of the lower lid. When the patient looks down, the cornea which press the lid, so you can see the bulging of the lower lid. This is not the monsoon sign, as you have seen in the previous picture. This is the monsoon sign. There is bulging of the cornea, bulging of the lid by the cornea. The cornea is pressing the lid, so there is bulging, notching of the lid. This is not the monsoon sign. The cornea is cone-shaped, and there is irregular seizure reflex on retinoscopy. If you do the retinoscopy, you can see the seizure reflex. The patient will have irregular astigmatisms. And if you examine with the pachytodix or keratometry or keratoscope, you can see the irregular corneal rings. You can see the flexure rings, epithelial iron deposits. There is loss, field loss also. There is central or paracentral scotoma will be seen in the field. And acute hydrops due to rupture of the disparate membranes. And the cornea will be edematous. These are the clinical features, signs of the keratoconus. Treatment: you should try to correct the astigmatisms. You can give the contact lens initially. Soft bandage contact lens will be the proper. We can use the hypertonic saline solution, 5% sodium chloride frequently. And you can plan for the EP keratoplasty or penetrating keratoplasty in such cases. Keratoglobus. It is a rare condition. In the keratoconus, there is central corneal thinning, whereas in keratoglobus, there is peripheral corneal thinning. And it is associated with Leber's congenital amaurosis and the blue sclera. It is familial occasionally, but it is rare in compared to keratoconus. Sakyu. This finishes the chapter of the cornea today. यो सक्यो कर्नियाको अब क्याट्राक्ट राखेको छु भने चाहिँ हेर्नुहोस् न क्याट्राक्ट पढाइदिनु